Thank you very much. Hello, everybody. So I know that you're all tired and you're behind in time, so make it hopefully fast. So I'm a nephrologist by training, so I take this opportunity to provide you a sample of untargeted lipidomics. The session objectives are to demonstrate an example as how an untargeted lipidomic approach is used to answer a clinical question, and also to demonstrate the analytic workflow in a step-by-step fashion. So for the audience who are not a clinician, chronic kidney disease is a major public health issue. According to according to CDC, there are currently over 20 million individuals with CKD in the United States. It's associated with higher risk of cardiovascular and all-cause mortality, and that's even at very early stages of CKD. And as the patients progress, the burden of disease increase. So by the time a patient reaches to end-stage kidney disease requiring hemodialysis, the cost is exponentially higher. By the time patient is on dialysis, the annual cost of dialysis would be over $80,000 a year. Just in 2011, the expenditure on hemodialysis was over $34 billion, which is larger than the entire NIH budget. So you would appreciate that this is a major issue. As clinicians, we have a vested interest to identify the at-risk patients at early stage, and the goal and the hope is to prevent progression to advanced stages of chronic kidney disease, which is associated with higher mortality and morbidity. So the first step to provide that goal is identification of patients who are at risk. How are we going to do that? So there are two biomarkers that we use very commonly in practice of nephrology. One is estimated GFR, and the other one is urine protein secretion. This is the classification by KDIGO, Kidney Disease Initial Global Outcome, that provided this classification in 2012. And you can see that the CKD spectrum is defined as different categories of GFR versus different categories of urine protein excretion. So if the patient has a normal GFR of above 90 with no or very minimal protein in the urine, that's the best. That's considered normal. And as the GFR categories drops or the amount of protein in the urine increases, you would see the heat map that with a red color that indicates association with bad outcome. So what's the problem with this classification? The problem is that first of all, you are dealing with a scenario that just by application of GFR and CKD, you could have a cross-sectional data that is associated with high outcome. So meaning that when you look at patients that are at a red area, technically it's too late. Patients are in their way to progress to end stage, and that's not really the right time to catch the high-risk patients. On the other hand, if you are dealing with patients at a green category, it's telling you that everything is just fine. However, you know that you could have patients with normal appearing GFR with no protein in the urine that can just progress to advanced stages of CKD. So by knowing the limitations of the current biomarkers, we know that we are not doing well because our currently available biomarkers are not identifying the high-risk patients. Worst scenario is that even the GFR measurement is a major problem. If you want to really measure GFR, it's a technically difficult task to do, and as a result of that, people have come up with a formula that incorporates serum creatinine, age, race, and gender to come up with estimated GFR. That adds another layer of inaccuracy to the estimations. So again, the currently available biomarkers reflect advanced stages of CKD, and at early stage, they have limited prognostic value with a wide margin of error. And therefore, we do not have prognostic biomarkers at early stages of CKD. The aim of this project is to identify lipids that can predict the progression of chronic kidney disease to end the stage at earlier stage. So how are we going to do that? So for the audience who's not familiar with CRIC, chronic renal insufficiency cohort is a multi-center cohort of patients with mild to moderate chronic kidney disease. It started recruiting patients in 2003, and the goal of the parent project was examining risk factors for CKD and cardiovascular outcomes, developing predictive models that would identify high-risk subgroups. The parent cohort recruited 3,939 subjects over a course of 5-year period up until 2008. So from that cohort, almost 4,000 cohort, we went ahead and selected 200 patients. The inclusion criteria were we wanted to not to be so low with eGFR, so we included eGFR of greater than 30 at baseline in patients aged 18 years and older, and defined a case as a group of patients who progressed to end-stage kidney disease needing initiation of dialysis in the next 6 years. Controls were basically matched by age, sex, race, and status of diabetes with case group, except that they did not have decline of GFR, or if they did, it was less than 25 ml per minute per year. Then we obtained the serum from a baseline examination, and we did the sample prep with the details that TM just explained the details, and in the interest of time, I'll skip the details. So we divided, basically divided the entire cohort into 2 subsets with the ratio of 2/3 and 1/3. The first 2/3 we used it as a training set, and the rest of that was used as a test set or validating set. And we used a bunch of different statistical methods to narrow down to candidate lipids that included a compound by compound comparison with FTR correction using t-test, a different kind of classification methods that included the application of PLSDA, a random forest, multiple logistic regression analysis, and we checked the classification power of the proposed biomarkers with the details that you will see in a few minutes. This is the snapshot of the first set of data that comes out of mass spec, and we get it from our bioinformatic core, and that's basically what Tanu provides to us. So to orient you to the structure of this data set, the first 11 rows are the internal standards that we spiked into each sample. And starting from row number 12 and beyond, everything else are the endogenous lipids that were detected by LC-MS. And each column is each one of the patients. And as you can see, we have some missing here. that I highlighted in yellow. So the first task would be imputation of missing data. So we used a K nearest neighbor imputation technique that was followed by internal standard normalization. The rationale for internal standard normalization was that we saw some minor batch effect that required normalization, and we thought that the best method of taking care of that and eliminating that batch effect has been by using the internal standard for that purpose. That brought us to the next iteration of the data. As you can see, all the missings are imputed. The question is it good enough data to be used for downstream analysis? And if you look at the distribution, the answer is no. You have a lot of skewed data to the right. Data is not normal. It's not having a normal distribution. So to take care of that, we use a log2 transformation, which oftentimes take care of the skewed data. And because we want to compare all the lipids together, we want to have a unique scale, and therefore we used a z-score normalization in order to transform all the data based on their standard deviation. So that brought us to the last version of the data, and the question is it now a good data set? And if we look at the distribution, you see that it's nicely normally distributed, and that convinced us that we can use this for downstream analysis. So this is the clinical data of the same patients. 121 patients remained non-progressed. We identified 79 progressors that progressed to end-stage kidney disease, and these are the background variables. And as you can see, the background variables are fairly balanced between non-progressors and progressors as we try to do a good job with matching. This is the rest of the clinical background variables, and still, again, you would see non-significant p-values, suggesting that overall the cases and controls were identical, except for their outcome. You can see that their GFR and protein excretion at baseline have been different. Progressors were a little bit having lower GFR at baseline by 10 ml per minute, which is technically an issue, and I'm going to explain to you how we address that problem in the downstream analysis. This flowchart demonstrates the flow of the study. As I explained, we split the entire cohort into a 2/3 training set and 1/3 validation set. We initially identified 510 lipid features. Initially, 128 were eliminated because we thought that some lipids that we are sure are not going to be part of the candidate biomarkers could be eliminated by application of interquartile range filtering method. That brought us to the next step where we had the 382 lipids. Out of 382 lipids, 49 passed the critical threshold of 0.05 on nominal scale. It's just simple compound by compound comparison of lipids by t-test. But then the question is, because of the issue with multiple comparisons and false positive finding, how are we going to address that? This is where we tried to narrow down further by those that just passed the FDR threshold of 0.05. And by doing so, we found 10 biomarkers that passed that critical threshold. But other than just looking at FDR threshold, we also used two other classification methods. One was PLSTA, and one was random forest ranking method. By doing PLSDA, we incorporated all the 49 samples in, and we further saw what the top 10 were and converted with what we got from FDR, and the same method with random forest. Then from the top 10, we further narrowed down by application of logistic regression model to see what are the independent predictors that remain after eliminating those that are either non-significant or are highly collinear with more significant ones. These are the list of top 10, and this is the simple t-test, and that's the fold chain, and this is the nominal p-value, and that's after correction by FDR. This is the unadjusted logistic regression model that provides the odds ratio for the corresponding lipid species, and this column provides you with adjusted logistic regression coefficients and estimations, and you would see that overall the lipids that are identified by FDR, by PLSDA, and by random forest are about the same, suggesting that no matter what kind of classification method you're using, they have good convergence, and the outcome of the methods were highly concordant. So this is the this is the forest plot of the 510 lipids, and these are the top 10. And as you can see, they are mainly consisting of deacylglycerols and cholesterol esters. So this is the log fold change in positive direction, meaning that if a biomarker is in the positive area, it is the higher level of that is associated with higher level of progression, and if it is in the other side, and if it is in the other side, the lower level is associated with progression. So these are the different classes of lipids that we identified, and if you look at the top 3 rows, you would see that those are the ones that are highly enriched among the classes of lipids. For example, in cholesterol esters, we found 15 different and distinct lipids, of which 10 have passed the critical threshold of 0.05 after FDR correction, and that's highly significant. Same overrepresentation class enrichment analysis showed the same thing for deacylglycerols as well as PE class. For the others, you would see that we either didn't find any lipid that passed the critical threshold, or very few that, as compared to the number that were identified in the platform, suggests that they did not reach to statistical significance and they are not enriched in the analysis. So as you remember from the earlier numbers that you saw in the table, eGFR and proteinuria were different by baseline characteristics. So the question is, are those two variables the reason we are finding these lipid species, or the lipid species that are proposed are independent predictors of progression to end-stage kidney disease, independent of those two variables? So here we are showing unadjusted estimations. Again, with FDR, the top 3 predictors would be DAG32, DAG36, and MAG16. And with random forest, one more lipid is proposed, and with PLSDA, 2 more in monoacylglycerol class. Although DAG32, DAG36, and MAG16 remain the same in all 3 different classification methods. And as you can see, the significant odds ratio with a 95% confidence interval in the unadjusted model, And if in panel B, if you adjust for estimated GFR, you would see almost the same pattern as you saw here, suggesting that after adjusting with the GFR, results are unchanged. Here in panel C, it's adjusted after incorporating proteinuria. So even after adjusting for UPCR, results are not changed. And panel D is adjusting by both. And again, results are not changed. This analysis suggests that the proposed biomarkers of DAG32, 36, and MAG16 are independent predictors of progression, no matter what baseline eGFR or proteinuria patient had. This is a subgroup analysis by presence or absence of diabetes, and basically here we showed that it's also independent of diabetes because the results with and without diabetes were almost identical. So the question, the bigger question is, now we found these predictors. Are they adding any value to clinical practice? And are they doing any better as compared to what we already know from application of GFR and proteinuria? To answer that question, we're going to look at the area under curve of receiver operating characteristics and calculate the C statistics. So basically, if the incorporation of a biomarker increases the area under curve of the proposed panel, that indicates that, yes, it is improving the classification power. Here, you could see this is the training set in FTR where we used just the FTR methods, meaning the top 3 lipid biomarkers. The red line is the eGFR and proteinuria combined. And when we add the lipid panel to the baseline variables, it shows significantly increased level of area under the curve, meaning that C statistic has improved, and that's above and beyond what you got from baseline model. We carried that model that we developed in training set and tested in the remaining 1/3, which was in our test set, and we got exactly a similar result, suggesting that the predictivity of the proposed biomarkers remained to be valid in the test set. And we did with the other 2 classification methods, and if you look at the PLSDA developed model as or the random forest developed model, you would see identical results with improved C statistics over and beyond the base model. We did it in the entire cohort, combined training and test set, and we repeated the tenfold validation method. And again, we are showing that by adding the lipid panel to the base model, you get improved C statistics. And these are the area under curve that you can see. It improves from 0.81 to 0.91. And that's highly statistically significant. Okay, so this table is a little bit busy, but I try to walk you through the concept of biomarker discovery. Oftentimes finds its way by these 2 analytic methods, which are NRI and IDI. And oftentimes, people who are working in this field feel obligated to report these statistics, but are they important? So basically, the idea is that when you're using your base model, in this case, I defined it as UPCR plus eGFR. That model alone identifies a number of progressors correctly and a number of progressors correctly as well. And it has some errors here and here. The idea is that if we use the lipid panel or proposed biomarkers or add it to the base model, is it going to be doing any better? So if you look at the lipid panel, you could see that the number of correctly classified progressors and correctly classified non-progressors has increased so that the total accuracy increased from 60% to 80%. And if you add all three methods, all three parameters together, it is even better, and the accuracy increases to 88%. So the idea is, by doing so, is the number of total, correctly classified progressors and correctly classified non-progressors in the new model any better as compared to the old model or baseline model? And that's what NRI and IDR are testing. If the p-value gets to a highly statistically level, that suggests that the answer is yes. However, the problem with these two models are that they have a tendency to become positive. In another word, it has a tendency to inflate the positive results even if your data is not so good or is poorly calibrated. It's very well known, and there are multiple publications in the field. So if you just see a highly statistically significant NRI and IDI, when your C-statistics is not reaching to a significant level, you should take that with a grain of salt. This is another way of looking at the same data, and basically we are looking at the mean level of each one of the lipid classes that we found in progressors and non-progressors. And overall, we found that PE and MAG class in progressors were higher, and the other lipids were overall lower in progressors as compared to non-progressors. We also looked at the impact of acyl chain length and the number of double bonds. And we found that overall, for example, in phosphatidyl, plasmonyl phosphatidyl ethanolamine, the longer the acyl chains were, basically the lower was the level of lipids in progressors. And we think that probably it has a biological meaning which deserve further investigations that we are currently looking at. Okay, so in my view, this used to be bigger, but it's okay. So, here we tried to use Metascape and basically show how major lipid classes were interrelated. And by doing so, we can see that the major pathways that are available, I mean the major classifications, just show the lipids at their class level. For example, you would see triacylglycerol, deacylglycerol, sphingomyelins, without really showing much more details in terms of the high diversity within each class. And that's a limitation of the current software and classification devices that are available. So what to do about it? We tried to create some more light, shed some more light to this issue, and try to show that, for example, if cholesterol esters as a class is predictive of progression, what is happening within that class? And by doing so, we are showing that basically the relationship between the top 100 lipids that have passed the nominal significance with the major predictors of chronic kidney disease alters in what way. So how did we do that? We used a partial coefficient, correlation coefficient analysis and adjusted by multiple comparisons, and those that passed the critical FDR threshold remained in the final list, along with their interrelationships that are shown by different connections here. So at the end, we found a number of deacylglycerols, phosphatidyl ethanolamines, and cholesterol esters to be predicting progression of CKD to end-stage kidney disease. And we think that as deacylglycerol itself is a key regulatory molecule that is linked with several different pathways, including PKC, MAPK, NF-kappa B activation, VEGF, and inflammatory pathway, that is probably the underlying mechanistic explanation as how these proposed lipids are predicting progression to end stage. So this study, of course, has limitations. The major limitation of this study is application of untargeted. We just proposed what the biomarkers could be. The measurements are all semi-quantitative. We do not have absolute concentration. So we still feel the need for verification of these results in a more quantitative method with the targeted platform. And plus that this was just one cohort, we obviously need to replicate these findings with external validation, with other cohorts to verify what we found was real and impactful. In conclusion, we identified a distinct multi-marker panel which was able to independently predict the progression of CKD to end-stage kidney disease and improve the classification power of eGFR and UPCR when added to the base model. With that, I would want to thank my collaborators. This has been a teamwork, and without their tremendous help, we could not do this. And with that, I stop here, and I'm happy to answer your questions if there's any. Yes, please.
So how would you propose to translate a lipid panel clinically, especially one, with such specific lipid species?
Yeah, that's a good question. Basically, my proposal would be to make sure what we found is real. So that requires we have to quantify these lipids in a targeted platform. And by quantification, we need to say at what level you would have how much sensitivity or specificity of detecting patients at risk of progression. So that level of quantification is required for clinical practice. And with the untargeted platform, we are not there yet. That's number one. Number two, you would need a verification with external cohorts, and that's what we are working hard to do and replicate. Thank you very much.
Thanks, Farasad. And so thank you very much.